and oftentimes people keep describing ketamine, something that makes you hallucinate. If he didn't have Suboxone on board, would the same thing have happened as it did happen? Hey everybody, welcome back to the channel. This is Dr. B, and today I want to consider Matthew Perry's autopsy report. I think I can unmask it, demystify it, reveal some potential important diagnoses, discuss and consider certain issues that people seem to be shying away from for a whole host of reasons, and I don't really care why, but I think the crux of the issue has really not been brought out. I think this is valuable because it will give you a better understanding of the overall situation. It will also educate those that are in need of education, which is really all of us. And again, I want to thank Matthew Perry, if you refer to my first video about him after his passing, that he is allowing us to use him as a tool to educate not only about substance abuse, but about general health issues. Let's get started. Thank you, everybody. Okay, let's get started. So Matthew Perry's autopsy report, cause of death, acute effects of ketamine, ketamine toxicity, whatever you want to call it, secondary contributing causes of death. They list first as drowning, then they also add presence of Suboxone, buprenorphine, in addition to cardiovascular disease, coronary artery disease. He did have all of these things going for him. Let's look at that. I think I can demystify some of this in a way that might be more useful for you. Let's start off with the first and what I think is a general important thing of how I would approach this as a clinician. When I look at that autopsy report, top to bottom, and going through every organ system, what do I see when they present his lungs and the state it was in, his liver, the state it was in, his cardiovascular system and heart, the state it was in, his kidneys, his pancreas. Overall, what do I see in there? Okay, Matthew Perry was in his early 50s, and what I see, what I can glean off of there from years of clinical experience and working in substance abuse, what I see is a 53-year-old who had a body of a 80-year-old from years of abuse, okay, of how he took care of himself, which clearly he was a known and admitted drug user, okay, including alcohol. And that really does in some ways declare itself of his overall general presentation as it comes out of the autopsy report. This is important. Why? Because it tells me that this guy had minimal reserves to fight any onslaught of pathophysiology, whether it's a disease, acute disease, or trauma, or environmental, which I kind of put into trauma, and in this case, drowning. Okay, that's what it tells me overall. That's all you really kind of need to know about that, all of those things. Now let's go to the big thing. Everyone's talking about ketamine in his system, the levels that was in his system, and everyone describes what ketamine is. For some reason, nobody's really talking about or stating a very obvious and simple fact so people can get a sense of what ketamine really is. I think the best way to present ketamine is from a historical perspective. And the way I want to start that is, do you know what PCP is? Angel dust, that drug that supposedly makes everybody go crazy and they can fight off 10 cops. Okay, ketamine is a drug that is both clinically and structurally a sister of PCP, to put it in simple terms. Ketamine is the sister of PCP, okay? That's important to know. That's important to state. I think it tells us quite a bit about what ketamine really is. And I'm a big fan of ketamine in the right and appropriate setting. To understand it better, let's continue to look at it from a historical perspective. PCP, discovered in the 20s. In the 50s or 60s, it was, I guess, FDA approved, and it was meant to be, it's a dissociative anesthetic. That's the class of drugs. It is a dissociative anesthetic, okay? And what ended up happening as they started to use it is patients, I think up to 30% of them, started having this really nasty thing, which we call now emergence reaction. When they would wake up from anesthesia, they would be really dysphoric and in a very agitated state. And it was frightening and difficult for the patients to deal with, as well as the clinicians. Eventually, it got pushed to the side as far as use in humans and became a veterinary anesthetic, PCP. Over time, PCP gained prominence, and you could see that alongside hallucinogenics, okay? And dissociative anesthetics are not hallucinogenics. This is important, okay? People often confuse them, mix them up. It's often mixed into the drug supply of both when used illicitly, but dissociative anesthetics work on the NMDA receptor antagonist. Hallucinogenics, we're talking about serotonin. Now, the pharmacology is a lot more complex than that. That's important to know, and oftentimes people keep describing ketamine something that makes you hallucinate. It is not a hallucinogenic, and for the most part, that's not true. Okay, PCP shelved as something used for humans, pushed off to veterinary medicine. You'll see its use in the 60s, 70s, along with hallucinogenics. And even to this day, there's waves of abuse as supplies come into cities. And you could sometimes see people coming in on PCP in the emergency department. So, ketamine is a sister drug of PCP. Here's what you need to know about that. It is 1/10 as powerful as PCP, and they were able to label it and use it as a general anesthetic class, more particularly a dissociative anesthetic. Okay, what that means, it's sort of you have this sort of out of body experience. It disconnects the mind from the body, and even more particularly, it's used oftentimes in the ER, in critical care ICU unit, for what's called the rapid sequence intubation as part of the cocktail to put someone under anesthesia to put a tube down their throat. The other area, ketamine, is often used, and I used to use it very much in this area myself, on kids, on children. Why? Because they don't have that emergence reaction that adults do. It's a great drug because you can deliver it without starting an IV. You can give it intramuscularly. It is relatively airway protective and safe on the cardiovascular system. It doesn't drop the blood pressure. Again, this is all dose dependent. You got to understand what I'm talking about here. And you can use it to sew some kid up, put a bone back in place, do all kinds of painful procedures. So it's a wonderful drug in the right setting. I didn't use it for rapid sequence intubation myself. I used Versed, a benzodiazepine kind of a class thing sedative, and the whole cocktail, which included a neuromuscular blocking agent and a pain agent. The other part about ketamine is it is also an analgesic, right? So when you use it in a procedural sedation, or if you're putting a tube down someone's throat, it not only sedates and calms the person down, and they're not reactive and responsive. It also deals with the person's pain, and we like that. Okay. Now, when the 2000s came around, okay, and the opiate epidemic, and everyone wanted to get away as far away from opiates, it started to be used more and more as a pain medication, especially in the acute setting. And it was really an adjunct or the second or third line, but it works great for managing acute pain, even in trauma patients. In fact, on many ambulance services, depending on the county, qualifications, et cetera, they use it out in the field for managing pain. It's used in the ER for managing pain. That came around in the 2000s, okay? So it's used for procedural sedation, for rapid sequence intubation, for pain management. Not sure if it's FDA approved still for pain management or not, but the other anesthesia uses are FDA approved. It's great on children. And the other area we use it for is to, believe it or not, remember, we're talking about a sedative and something that decreases respiratory rate, and I have something to say about that later. You can use it for asthma attacks. Now, it's not necessarily first line, okay, but in many countries it is. It's cheap, easy, accessible. That's what ketamine is. In the most recent years, right, we started to see, again, it's a complex pharmacology, that it could have benefits for drug treatment resistant depression. It could potentially have benefits even for PTSD, anxiety, a lot of psychiatric issues, okay? And today, S-ketamine, and that's not S, it's ES. S-ketamine nasal spray is FDA approved under the supervision of a psychiatrist, very well controlled by the government, by the Controlled Medication Act, all that stuff. And it is approved for treatment-resistant depression. You will see a lot of ketamine clinics out there. And again, there's quite a bit of data out there on this stuff, okay? But you'll see a lot of ketamine clinics out there that do ketamine infusion, and they don't just do depression. It's anxiety, it's OCD, it's PTSD, and some may even be doing it already for substance abuse. That's what Matthew Perry was in. He was in that group, as far as I can tell, of ketamine infusion clinic, and maybe for depression, but these guys really kind of push the limits of the indications that they use it for. Do I use these things for my substance abuse patients? Do I promote ketamine for depression because we deal with a lot of mental health? I don't. If the patient chooses to do so, they can. Why do I not? Here's why. And maybe this is why I'm not rich. Simply because whatever comes out, and there's sort of a gold rush from the medical establishment to use it for, it's a panacea for treating everything. I stay away. I'll wait a couple of years. How many times has there been things that it's going to solve all the issues? In the 70s, Valium, we moved away from barbiturates. Then the Z drugs like Ambien, non-addicting, okay, turned out not to be true. I wait 2 years, 3 years, 4 years. If a patient wants to do it, I don't stop them, right? But by the time I usually get on things, the financial rewards are also gone. But I want to make sure before I put patients on anything that it has had sort of a shelf life out there of use. Okay, Matthew Perry was on this stuff, okay? And the amount that he had in his body, okay, was anesthesia levels. One of the things I want to point out is they noted they cannot comment on route of ingestion, yet trace amounts of it was found in his stomach. Okay. He obviously took a whole bunch of this stuff, and it has a short half-life, so it can't be from the week and a half ago when he had gone to the infusion clinic for ketamine. This was from another source. Now, whether a doctor was prescribing it or not, I'm not 100% sure, and I don't think we know that at this time, but he took enough of this stuff, and basically, very simple, he went unconscious in the hot tub, then his head went down, and he drowned. He doesn't seem like he was in there very long, and that's sort of a clinical gestalt from reading the autopsy report that I have. So, I'm not going to, make a point about that. So his head drooped and he drowned. And as I said, his overall reserves were minimal. So he drowned quite fast. That's that. And we'll talk about why was he on this stuff in a minute, okay? Now let's go to the other things. They talked about drowning, okay? No, not too controversial there. Then they talked about Suboxone being on board as a contributing factor. I find this issue, his Suboxone levels were therapeutic, and I don't know if what dose he was actually on. I understand why the medical examiner put that in the report. It's in the literature. Nevertheless, clinically, I'm going to put it to you this way. If he didn't have Suboxone on board, would the same thing have happened as it did happen? I say 100% yes. Okay. I do not believe, given the literature, that his respiratory drive and respiratory depression was that affected, if at all, from being on chronic Suboxone use. And I think this is very important to point out because we're dealing with a medication that absolutely categorically saves huge number of lives by the number and has a lot of stigma attached to it in the United States. And this report can potentially cause even more stigma and concern. So let me say that again. I do not believe if he did not have Suboxone on board at the therapeutic doses, it would have made any difference. And I feel that 100%. Let's move on. There's something more concerning here. Okay. He did have Ativan on board at a therapeutic dose, which is also a sedative, but that's not listed as something contributing to the death. In addition, he had metabolites of Klonopin, another benzodiazepine, on board. And they know, but there's no Klonopin in his system. Yes, there's no Klonopin in his system. It's been a few days and it wasn't contributing. But this is significant for other reasons. But certainly, as far as contributing factor to cause of death, Suboxone is listed, Ativan is not listed. I kind of understand where the medical examiner is coming from. I'm not faulting him, but I think it's my duty to point this out clinically and educate the public that my clinical opinion strongly is that if there was no Suboxone on board, it would not have contributed, it would not have saved him in any way. He had so much ketamine on board, probably from oral route, that it would have not made any difference. Let's move on. I want to point something out about his overall state of health. As I said, his overall state of health, given my experience, and it's quite extensive, and what I see top to bottom on the autopsy report, and knowing his history, his body and his overall reserves were minimal, and his body was quite beat up. As I said, maybe like an 80-year-old, okay? One thing that would tell me about his current state of health in terms of him taking care of himself and trying to turn things around would be his hemoglobin A1C, right? And that's a biomarker in the blood that has it looks back in time over the last 3 months about how well you're controlling your sugar, given the fact that he was a diabetic. That tells me a lot. It tells me a lot about his current mental health, his seriousness about his health. Keep in mind, his BMI was 31, which is slightly obese, right? Usually when people start taking really good care of themselves and taking their diabetes medications, it really starts with diet, exercise, weight loss, and they can see quite a bit of turnaround, especially in type 2 diabetes, which is probably what he had, it seems like. Okay. Another area that is of significance and nobody is talking about is when you look at his autopsy report, besides medications, I think for cholesterol, diabetes, so forth, he was on a boatload of psychotropics. Okay? You're talking about Seroquel, sleep medications, antidepressants, anti-anxiety medications. We also know that he was taking both Ativan and Klonopin at some points here. That's on the report. Now, none of that was in his body, right? That's on the report. I think it was all found at the scene. I don't know if any Klonopin or benzodiazepines otherwise were found on the scene. But this guy had a diagnosis that's critical for me to understand if he walked into me as a patient. One of his diagnoses would be polypharmacy, and a messy polypharmacy, because when you look at it as diabetes medications, his blood pressure medications, some of his, and I don't know if they look for these and they state these, but they didn't seem to be on board. And again, I don't know if they look for these and state them on the autopsy report. I didn't see anything, but he had the diagnosis of polypharmacy with a large number of psychotropics. We also know he was taking Klonopin. We also know he was taking Ativan. We also know he had been prescribed a lot of antidepressants, sleep medications, okay? All of this kind of presents a better picture. And the things, if we're just simply talking about the autopsy report, I think it's important to know, Ativan was in his system. You should write that as contributing to his overall depressed, sedated state, even though I don't believe it did contribute, but I also don't believe buprenorphine had much contribution either. It's basically ketamine, large doses. It was 3,000, I believe, around there, both in his peripheral system and around his heart. They take the blood samples from two different areas in autopsies. And he went unconscious and he drowned. So why was he on the ketamine? I don't know. I want to address this in another video, but I will say this now. What was the cause of death as I see it? Yes, certainly acute toxicity of ketamine, being in the hot tub and drowning. I would stop there for me clinically as far as things that are important and significant. But when I look at the overall picture, okay, I would say he was somewhat of a victim to his and celebrity status, celebrity culture, what a person can get away with, what others do to appease that person, financially driven medical establishment that we live in, potentially too many doctors, too many cooks in the kitchen, maybe lack of communication with providers, and not getting true professional support for where he was at in this long road of recovery, the marathon of recovery, the marathon of being sober minded, the marathon of making good decisions, the marathon of coping skills that you never learned for everything that went wrong long ago. Very particular feelings and views on this issue, and I want to continue it potentially in the next video. For now, I want you to understand ketamine is the sister drug of PCP, okay? And it came up that way as an anesthetic, dissociative anesthetic. It's not a hallucinogen, okay? The indications for depression, the indications for mental health issues came a lot later and are not FDA approved and are not true indications except in a psychiatrist's office where you're getting a very closely related compound to a nasal spray, esketamine. His polypharmacy tells us quite a bit about his mental state, his disposition, his decision-making capacity and processes. Suboxone is just as much of a contributor to his death as maybe his Ativan was. And I don't really think either one was a real contributing factor, because if you take them out, I don't think anything would have changed given his ketamine levels. I hope that helps. I hope that clarifies some things. I hope that educates. I thank Matthew Perry again for wherever he is. He was a complex man, a lot of demons, huge struggles clearly from his medication pharmacy layout. And I hope you all gained something from this video. Thank you very much. See you next time. Please don't forget to subscribe and like. Peace.